Hello, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a few quick housekeeping items. The Private Practice Simple Solutions program is a series of rapid learning cycles designed for private practices to provide opportunities to implement actionable changes that can immediately increase efficiency. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific advice. Please take a moment to carefully review this notice. I'd like to now introduce our speakers who will be leading us through today's content. Dr. Janine Engel, Associate Professor of Medicine at the University of Virginia, and Dr. Kevin Hopkins, Senior Physician Advisor for Practice Transformation at the American Medical Association and Primary Care Medical Director at the Cleveland Clinic. Please go ahead and take it away.
All right, thank you. And thank you all for joining us for the content that we hope to provide today that I know will be interesting and stimulate further discussion and probably additional questions. We're thankful to have Dr. Engel with us today, and I'm going to be sort of moderating our conversation by posing some questions that have come in through the platform from those who watched or listened to her first webinar relevant to E&M coding. And so these are some of the topics that we will touch on throughout the course of our time together today. We'll talk about medical decision making and specifically assessing risk associated with medication monitoring. We'll discuss billing more than one service at a time, so an E&M encounter plus also preventative services or in-office procedures. We'll touch a little bit on telehealth and telephone services. We'll also discuss billing the appropriate level of service for the work that's completed and the work that's documented. And then we'll wrap up with a little conversation about appropriate level of documentation for the care that's being delivered. But we'll start with a question, Dr. Engel, that came in through the platform about medical decision making. And by way of background, I'll just say that from our first webinar in this series, we learned about billing visits based on either medical decision making or total time spent on the day of service. The 2021 CMS CPT update considers medical decision making in terms of three components, which you outlined: the number and complexity of problems, the amount and complexity of data, and the potential risk of complications, including mortality and morbidity. You talked in that first webinar about some prescription drug management topics, and as far as prescription drug management falling into a category of at least moderate risk medical decision making. The question stems from that topic. Are there situations when prescribing and monitoring patient use of some specific medications may actually cross over into high-risk medical decision making?
So thank you for that, Dr. Hopkins. So yes, there's a specific high-risk category that is designated for drugs that require intensive monitoring for toxicity. And this was a risk category under the old coding rubric as well, but has been included in the high-risk category for the 2021 outpatient E&M risk area as well. So it's important. There's a few things about this that I want to highlight. The first is that both the drug and the monitoring have to qualify here. And what has been helpful in this realm is that the AMA CPT panel actually put this into the CPT book and define this a little bit better. And so that's been helpful in clarifying a lot of the questions that come up around which drugs qualify, what's intensive monitoring mean, how do we decide as physicians whether the information that we're amassing or the monitoring we're doing qualify in this category. So for those of you who maybe don't read the CPT book in your spare time like I do, I'll give you a little bit of information out of there, but you can find this. And if you even Google drug therapy requiring intensive monitoring, you'll see this quoted by a number of coding sources and by some of the specialty societies as well. But they specifically say in the instructions that the monitoring is performed for assessment of the adverse events and not primarily for therapeutic efficacy. So there's this balance of saying we're monitoring this for toxicity, not for therapeutic effect. The monitoring should be generally accepted as best practice for this agent. And long-term, you can have intensive monitoring for long-term or short-term. So you might do this for a short period of time while you're just starting a drug, and then do it over long-term for the duration of therapy. They do specifically state that long-term intensive monitoring must be at least on a quarterly basis. So they specifically give an example of something that would not apply, which would be, for instance, annual electrolytes and renal function for a patient on diuretic therapy. That's not considered intensive monitoring, because while you are looking for toxicity, it doesn't meet the threshold of doing it at least quarterly. So examples that would qualify include monitoring for cytopenia with the use of antineoplastic agents, or short-term intensive monitoring of electrolytes and renal function in a patient in whom you might be upping diuresis or starting a new agent and needing to monitor for toxic effects of a new medication for that patient. The other thing that they specifically mention is that the monitoring affects the medical decision-making in the encounter in which it's considered for the management. And so you do have to consider that. One specific example that gets brought up a lot is, does Coumadin management fall into this category? And I think the answer is yes, if you as the physician or the provider are doing that management as part of your E&M visit. In my clinic, for instance, we have a Coumadin clinic. Our nurse, we have an RN that manages this, but I'm not doing it as part of my E&M visits with the patient. I mention it as part of their care, but the management gets done in between visits, and so I don't count this as part of my E&M visits when I'm seeing those patients, because that's not when the work is being done.
That's a specific nuance that I was not aware of, and makes total sense, right? So if it's maybe a lab test or something that the patient had done ahead of a visit, and it's being discussed at a visit, and it affects medical decision making for that day, and like you said, it's intensive monitoring. I like how they defined it as far as at least quarterly. So if it's something that's happening more frequently, then it might qualify for intense monitoring, but it has to be something that you're actually managing within the construct of that E&M visit, which you're considering for medical decision-making billing, right? So if it's outside of that, if it's taking place in telephone encounters or some indirect care that we're delivering, then we shouldn't consider it as part of the medical decision-making. That's right.
Yeah, I think that's accurate. And then I guess the other thing I would say is that, this this risk table will be applicable soon to the inpatient codes. And I know that's not what we're here to talk about, but my guess is a number of the physicians and providers listening to this webinar do inpatient medicine as well. And so this will apply on the inpatient side as well. And there are many of these drugs that we do intensive monitoring on the inpatient side that would push patients into high risk. For instance, intravenous narcotics when patients are on a continuous oxygen monitor to monitor for respiratory depression, that kind of thing. So that's an example that we are more likely to see on the inpatient side than we would in an outpatient clinic.
So other medicines that I can think of that might be worth considering if they require intensive monitoring, and I don't know if you want to address these specifically or like individually or sort of a blanket statement regarding them, but things like anti-epileptic drugs, controlled medications for anxiety, for ADHD, controlled like chronic narcotics, for pain syndromes, things like that. Would those fall into the category of intense monitoring for medical decision making?
I think it's tough. So let's talk about, chronic narcotics. I guess the question is, what's the, what is the monitoring that you're doing? Oh, and they specifically, I should say this as well. They mentioned that that the monitoring should be a lab, a physiologic test, or imaging. And so I think the monitoring that we tend to do for narcotics is checking the controlled substance website. I guess we are often doing during drug screens, which would qualify as a lab test. And so I think it depends on your state rules and regulations about how often you're doing that urine drug screening. And so if you are doing that at least quarterly, then and that is looking for, in essence, looking for toxicity by looking for other drug usage, then I think you could probably have that qualify. I do have a number of patients on chronic narcotics, and in my state, it is not required that you do the urine drug screen quarterly. I have some patients that I do it on quarterly and others that I don't, based on my knowledge of them and their history and those kinds of things. And so I think that's one that you have to look at the definitions carefully, look at your state regulations, and then make a decision about whether in specific patients that meets for the intensive monitoring for toxicity, and also whether this patient's maybe at higher risk to be on narcotics simply because of who they are and their other comorbidities.
Yeah, great points. Okay, well, let's go on to the next topic, which is billing more than one service within the same visit or patient encounter. So often patients will come to an ambulatory visit, let's say, with more than one agenda item. And sometimes it's multiple acute symptoms or chronic conditions, or more frequently, it's sort of a combination of both. A situation with which I'm very familiar as a primary care physician is a patient who comes in for a preventative visit. Could be an adult physical, a well child check, a Medicare annual wellness visit, and they also have some acute or chronic conditions to be evaluated at that same visit. Many of us probably just lump the diagnosis codes for these additional issues into the preventative visit billing code and sort of go on with our day because we don't have time to think about it necessarily. But is that really the right way to handle this type of circumstance, or should we be billing more than one code for the same visit?
So yeah, this is a great question, and I think one that comes up in pretty much every talk that I give about billing. So I'll tell you, we'll start with sort of the regs, the regulations on the Medicare side. So Medicare annual wellness visit, they explicitly state that you can bill an evaluation and management code on the same data service as an annual wellness visit if there are services provided above and beyond the service given for the annual wellness visit. So if you're managing during the visit hypertension, diabetes, hyperlipidemia, or an acute problem, in addition to completing the elements needed for the annual wellness visit, it's my opinion that you should be billing that E&M visit in addition to the annual wellness visit. You would attach a 25 modifier to the E&M visit, and then you would want to link the appropriate diagnoses to the annual wellness visit as well as to the E&M, so that the appropriate diagnoses are submitted for each of the services. Now, the barriers to doing that, the patient's expectation is probably one of the biggest barriers, because patients often, when they're coming for the annual wellness visit or the annual preventive, their expectation is it's a free visit. Not sure if you guys can see me and my air quotes there. So they're coming with an expectation that they're not going to have a copayment for that visit. And often they think that everything that they're getting done, including any labs or anything else during that visit, also will be bundled into that no cost visit for them. And so that requires some education to the patients so that they understand that if you're managing for medical problems, that's not part of their annual wellness visit on the Medicare side. And the same is true for commercial payers as well. So to flip to the commercial payers for a moment, this really depends on contracting. So I can't make a blanket statement about whether an annual preventive visit plus an E&M will be covered on the same day under commercial payers, because that's really a matter of contracting. And over the years that I've been doing this, I've definitely seen times where it's not included in contracting and other times when it is. And so that can be really challenging because the patients don't know, and often the physicians, sorry, I work at a big academic center, so the physicians don't know that at big academic centers. When you have docs in smaller practices, you may absolutely know what your contracting covers. And so I don't mean to besmirch the knowledge base of people and their contracting in smaller practices. So I think those are the barriers. The barriers is knowing what the coverage criteria are, and then the patient's expectations. My personal belief is that as primary care docs, if we don't, and really any practicing physicians, if we don't bill for the work that we're doing, we're really hurting ourselves and our patients ultimately, because we're not demonstrating the amount of work that's being done in the offices, and it's giving away work for free, which ultimately hurts us and our patients. And so I do think it's important to bill for the work that we're doing. And then the other example would be a procedure plus an evaluation and management code. So if a patient comes in with, I'm gonna demonstrate where I grew up medically, which was in Nashville, Tennessee. So people come in with a spider bite, that's an abscess, people. I learned that in the first 6 months that I was working there. So patients come in with their spider bite, it turns out to be an abscess, and it may need an incision and drainage in the office. And but you don't know that when they come in, and you have to evaluate the problem and then make a decision to do a procedure. So if that's the case, you can bill both an evaluation and management and the procedure on the same day, again with the 25 modifier. If, however, a patient comes in for a visit and they have multiple skin tags that they want removed, but you don't have time to do it that day because you're running behind, or you just have a really busy clinic, and so you schedule them to come back in a week just for the skin tag removal. When they come back for that visit for the procedure only, then you would not bill an E&M because you've already made a decision to do the procedure and there's no evaluation to be done. So it really has to do with what's the work that you're doing at the time of the visit. If the procedure required an evaluation to make a decision, am I doing it or not, then you should bill for the evaluation, the E&M, in addition to the procedure.
Okay, those are great examples. And I've seen, as far as the preventative care and the acute or chronic care being done at the same time, I've seen people handle that in different ways, and I'm sure you have too. I've seen some people where they just say, no, I can't address those issues today. We're only doing your wellness visit because I don't want to, the unstated fact is I don't want to get calls and complaints later about the billing associated with it. So I'm just going to do that. We'll have you come back for a separate visit for these other issues. And then I've seen the opposite, where people just sort of lump it all together. They throw all the charges in and sort of hope for the best. Any thoughts about maybe best way to handle that, or even best way to, what's our responsibility to make sure that the patient knows what they're in for?
Yeah, I think that's incredibly tough. You know, and I think no matter what we do, there's still going to be patients who complain or are frustrated or don't know. You know, I think back to our pediatrician in Nashville. You know, I think in some ways the pediatricians out there do this the best. I mean, they have big signs all over the place that say, you know, if you're here for your kid's well child check, you know, that is all we'll be doing. And if your child has, you know, an illness, then we will defer their well child visit. I mean, they're really, really clear about what they're going to do during a visit, and differentiating those well child checks from sick visits. And I don't think we don't do as well on the adult medicine side at sort of as sort of managing that. And so I think you can do it, with lots of information up front, with checking, with having your front desk folks when they're being checked in, be really clear about what are you here for today. But I think no matter what, it still ends up falling to us in the room sometimes, or at the back end. And, I'm not a fan of spending my clinic time with patients talking about billing, but I do sometimes. And I try to make it clear to them, what's gonna happen. If they're there for a wellness visit and then they want to talk about 6 problems, I tell them, like, that's a different kind of service than what we had you come in for today. Today was meant to be talking about your wellness and your preventive services and going through all of that. And if we're going to spend time on this other thing, then that's going to result in a couple of different charges being submitted to Medicare. And that's usually how not is like, I'm going to bill you, but we're going to submit charges to Medicare, is how I often phrase it. So I don't know a great way to do this that doesn't end up pissing some people off. Sorry, I probably shouldn't have said that on a webinar. Oops.
Well, I think all of us can understand what that means, and we'll be able to relate. So we'll move on now, and let's touch a little bit on telehealth and telephone services. So this is something that's changed a lot, right, as a result of the COVID-19 pandemic. I know here in our health system in Cleveland, over the course of about 2 days, we went from less than 0.5% of our visits taking place virtually to over 90%, at least of our primary care visits taking place virtually in early 2020. So it certainly accelerated our use and patient adoption of telemedicine, virtual visits, and other non-face-to-face services. CMS and other payers have eased requirements for these types of interactions as a result of the public health emergency. So knowing that there's some time nuance to this, could you give us a summary of the current state of billing and coding rules specifically pertaining to telehealth and telephone encounters? And then maybe what do you think the future state answer to that same question would be?
Yeah, so this is an ever-changing, ever-evolving bit of our medical care right now. And so I want to start by saying there's actually a really great website, telehealth.hhs.gov. So I'm not always a fan of government-based websites, but I got to tell you, this one actually is really well done. And there's a patient section and a provider section, and it really it's kept up to date with lots of links to other areas. So telehealth.hhs.gov. So Health and Human Services. So the current state is that we're in the public health emergency. It was last extended on July 15th for another 90 days. They have said, the secretary of the HHS secretary has said that they will give states at least a 2-month notice prior to ending the public health emergency. And so that means that there'll be at least a 60-day notice before it's going to end. In addition, legislation was just passed that will extend all of the exceptions under the public health emergency for 151 days after the end of the public health emergency. So in essence, we should get is essentially a 7-month buffer to know that the exceptions or some of the things we've been able to do under the PHE, that those things are going to be coming to an end. So the things that we're able to do under the public health emergency is that the originating site restrictions for telehealth services were lifted. So lots of people probably don't know this. Maybe some folks who are in really rural communities know this, but normally for Medicare to pay for telehealth, it requires that the patient is in a qualifying originating site, which means they're somewhere rural or in certain geographic areas, and that they have to be at a medical clinic or hospital. And so they couldn't be in their homes, okay? And so the big exception that was put in during the public health emergency is that they waived this originating site so that the patient could be in their home to receive telehealth services. So that's the big thing, the big waiver as part of the public health emergency that allowed us to be able to push out a lot of these telehealth services. So currently, we as physicians can be at our clinics or even in our homes and provide evaluation and management services to patients while they're in their homes, and Medicare and most of the commercial payers now will pay for that because they tend to follow Medicare suit. The other thing that they did is that they valued the telephone services, so the audio only services, which are the 994, 401, 42, and 43 codes, which previously were designated category I by CMS, which means they don't pay squat for them. They don't recognize them as codes. Not only did they start paying them, they actually increased the RVU value to be on parity with the 99212, 13, and 14 codes, so that patients who didn't have access to computers or stable internet could do telephone only services, and physicians would get paid the same as if they were doing an audio visual service. So that was really the big win that came as part of the PHE. And by win, I mean win for the patients and the providers, because we were able to get reimbursement for providing these services by phone at a time where it really wasn't safe for a lot of our patients to travel and come into the clinics and hospitals. So those things will remain in place until 151 days after the end of the public health emergency. And unless there is congressional legislation that changes that, that will all end. And so there's certainly a lot of pressure to change the laws around telehealth to allow for these types of services to continue. And that stuff is out there moving. Right now, there is not, there is no change in the current laws around these originating site restrictions for payment for telehealth services. And so everybody's really hopeful that this will happen. But for now, we're still operating under the public health emergency. I'll just briefly mention that there are some other codes. There's online digital evaluation codes, which are the 994, 21, 22, and 23, which are not reimbursed as well, but these are for patients that put in messages through, if you have an online portal, and then you respond to those messages over a period of time. So those are codes that are available, but you need patient consent. So again, this is the patients are like, what do you mean you're billing me for answering my portal message? You never used to do that. So that's irritating for everyone. And then Medicare has some virtual check-in codes. So these are G codes for similar things, which are also require verbal consent. This is the G2012-2012 and the G2252. These again are time-based codes. If patients either call or send a message, it's for patient-initiated inquiries. So there are ways to get other reimbursement for this type of non-face-to-face work.
Thank you. That was a great summary, and you're right. That sort of the future of the situation is indefinite, and when we get to that point where there is an end declared to the public health emergency, then really the clock's ticking and the pressure's on, as far as making final decisions about what happens thereafter. So, thank you for that. Let me ask you a question relevant to just billing the appropriate level of service. So this came up because in our organization here, we've started taking a look at level of service billing distribution, and we used to do that more regularly, but we've gotten back to it a little bit, and we're starting to see more and more of our physicians and APPs billing sort of low end level of service or lower end level of service, like level 1, level 2 visits, things like that on the E&M scale. So thinking about that specifically, and recognizing the fact that we now bill based on medical decision making and or time spent on the day of service, is it ever really appropriate, do you think, for a physician to bill an office visit for, say, an established patient as a 99211 or 212, like level 1 or 2 service, based on the current guidelines?
So great question. I think so important to know that the 99211 code is not a physician code or a provider code. It's a code that should be used at non-facility based clinics for things like a nurse visit or a blood draw or a blood pressure check. It allows some reimbursement for basically use of supplies that may come with those types of visits. I'm at a facility-based clinic, so we would never use that code, and we didn't in the past either. But we get to bill a facility fee, which reimburses us for those types of things whenever there's a nurse visit or that type of stuff. In terms of the 99212, this would be straightforward medical decision making. So let's work through that kind of quickly. One self-limited or minor problem, the data is minimal to none, and it's minimal risk. They don't even define what minimal risk is, okay? But it's kind of a nothing burger. And even before the 2021 changes, I would try to write clinical vignettes for these like a 99212. It's incredibly hard to write a vignette for a 99212. And that was like when there was still the history and exam. So taking away the history and exam, I could come up with a couple of things that could be 99212s, like follow up a resolved rash. So someone comes in for a follow-up visit for a rash that's resolved, and you're like, rash resolved, and that's your visit, okay? Because there's really no medical decision making there. Or an example, even like a poison, like a first time visit for a rash, I think is a 99213 most of the time, even if you just say go home and use calamine lotion. But evaluating a new rash takes some review of information. However, I do have one example of a new rash that might be a level 2. This is a true story where a colleague of mine in Nashville, their spouse had this red rash on their legs that they were concerned was petechiae. It turned out to be spilled Kool-Aid and rubbed off, but they ended up at the doctor with it because their spouse was a physician. And so when the doctor rubbed it off, they sent them on their way. So that might be a level 2 visit. But those are, and I'm sure there are level 2 visits, but it's actually pretty tough to get a level 2 visit, in my opinion, certainly in internal medicine.
And that's an example of a case where an alcohol prep pad could be diagnostic and therapeutic at the same time. So
there you go.
That's terrific. So yeah, great examples. And I think often we still think about the old billing and coding guidelines and sort of checking the bullets and things. And my opinion is I see a lot of physicians that sort of undervalue the cognitive work that we do. If I don't have to click and write and type, that's what I bill for. But the truth is, people are coming to see us because of our cognitive abilities, our knowledge and skill, and sort of the mental gymnastics that we go through in doing an assessment and evaluation of a patient, and thinking about all of those things that we sort of do subconsciously as far as potential negative or adverse outcomes if we don't take care of a certain thing. So I think it's important for us to think about, and I know I've heard you say it a couple of times, billing for the work that we're doing. I think that's vitally important.
Absolutely.
Sort of along those same lines, there's a lot of physicians I know that wish to avoid being sort of an outlier from a billing and coding perspective due to fear of having their charts reviewed or audited. Is there a way to audit proof your practice to avoid such a review, or at least ensure a favorable outcome if it were to happen?
So yeah, that's another question I hear a lot, and I don't think I've ever given a billing talk where I didn't have a physician or other provider come up to me afterwards and say, you know, I never bill level 5s because I think that I've been told that's what'll get you audited. And I think this is a case where there's really no such thing as being audit proof, because, you know, I've worked in a number of compliance-based jobs over the years, and, you know, I've seen 99213 get audited, believe it or not. I've seen, I saw a provider get audited for too many 99214s. I mean, WTF, like that's it's an internal medicine practice, like that's what you do, you know. And the audit was fine, like we sent in, you know, notes, and they all were fine. So there's no way to be audit proof. If an auditor, in my opinion, if someone gets a bug up their belly to audit somebody, they're going to find a reason to audit. And the way to be audit proof is for your documentation to support what you're billing. And, you know, we had a practice in Tennessee where I worked, where they billed almost all level 5s, but that's because they saw super complicated patients with, you know, hard to control hypertension, and the work they did supported level 5 services. And I had that provider ask me, like, should I be billing, you know, should I bill some level 4s so I'm not all level 5s? I'm like, no, you should bill for the work that you're documenting and the work that you're doing. And so the way to be audit proof is to have your documentation support what you're billing. And I certainly see sometimes where that's not true with physicians, because they don't understand the billing rules. They're not documenting, you know, they're not choosing levels of service based on the work they're doing or the work that they're documenting.
Yeah, and it's really not a reasonable solution to think, well, I'll just underbill or undercode everything, because we also have responsibility to our practices, right? And those of us that do work in larger organizations, to our organizational goals and responsibilities.
Sure.
One last thing, and it gets back to sort of some takeaway points that you had for us in our first webinar of this series. At the end of that, you suggested that one of the takeaway points should be physicians review their electronic health record note documentation templates. So taking that to heart, I've started reviewing my own templates for opportunities to really streamline them by removing some unnecessary information and maybe links that pull data in from other parts of the EHR into the visit note. Why do you believe it's important to do this? And do you have any recommendations on even how to start?
Yeah, and I think, again, a lot of this is personal preference. What's important to you? Like, how do you use your notes as well? So I do think that's important too. And, you know, I since moving to Virginia 2 years ago, I picked up 2 different practices from retiring physicians, and they had very different documentation styles. And I will say that one of the docs tended to leave a lot of information in their note from over time, and not so much, you know, like lab data and that kind of thing, but more their medical decision making over time. And I got to say that was super helpful to me, because I didn't have to go back through, you know, 15 years of notes to see what had happened in the past. So that, you know, I have to say, I think this physician did that for themselves to they could remember things over time. That was really helpful. So I do think it's important to think about, like, how are you using your notes? What's important to you? I think about, when I read a note, what do I read? When I read another physician's note, I don't read all the stuff in the middle that has like 5 years worth of lab tests and x-rays that have been pulled in. I literally don't look at it. I look at the HPI and why they're being seen, and then I go to the assessment and plan. And so when I'm writing my own notes, that's what I concentrate on. And I don't tend to my templates don't pull in any data. If I think the data is important, I put it in myself, or I say I reviewed it. Now that's my personal preference. That may not be everyone's preference, but I think this, you know, these notes that I see were literally 5 years of, you know, echoes and every imaging study the patient's ever had and every, like, I just, maybe it's helpful to that provider. I'm not saying they shouldn't do it because maybe that's how they think about the patient, but it certainly isn't helpful to me when I go to review the note. If I want to look at somebody's echo, I just pull up their echo and look at it, So that's just that. So I think the way to do it is think about, how do you look at notes? What do you need in your notes to communicate with yourself and others? And are you putting extraneous information in the past because of what were the documentation guidelines? And could you, instead of doing that, could you leave that out to make your notes a little more streamlined and easier to look at?
Yeah, those are great points, because there's multiple reasons for the note, right? It's not just about billing, because if it was just about billing, they could actually be a lot shorter now.
Indeed. Yep.
But we're communicating with our future selves. We're communicating with other healthcare professionals, and really now with open note access through patient portals and things like that, we're communicating more directly with the patients too. So there's multiple purposes where it may be more appropriate to store some of that year's worth of data somewhere else in the chart. It already lives in a place, but maybe in the problem list or somewhere else other than the visit notes, and keep perpetuating that. And I've seen folks sort of copy their previous note and then not make the requisite edits and changes. And so the information that it contains is old and irrelevant to today's visit. So it actually can create confusion and be less helpful rather than more helpful.
For sure. All right, well, I think we're at our time, so we'll we can move forward. This has been a great discussion. I hope it's been helpful to our listeners. And I'll just remind everybody that we have a discussion board on the PIN website. There'll be some continued office hours about once a week. I'm checking in to make sure all the questions are being answered and reviewed. And so once this webinar is posted, there'll be some remaining office hours through the end of August. And I'll look forward to connecting with folks there and answering any remaining questions that may come up, both from the original webinar or from any new information that we've shoveled at you guys here. So Dr. Hopkins, really appreciate the opportunity to have this discussion with you. And look forward to connecting with some of our listeners on the website.